Okay, so as I said, we'll be going on a video-based discussion, and I'll show some clips and keep a discussion open between our expert faculty to discuss about the various situations or differences that they would do while doing similar situations. Uh, what we'll start off with is the wound construction. The first part is the retinal detachment based vitrectomy surgery, but wound construction is common to all. So this is the way usually I make the wound. I just go in a biplanar way, go in, just hold the conjunctiva with the forceps at some place where I feel the fixation is good. Just go in an oblique manner and turn it towards the optic disc and come out. So the present generation of the cannulas allow you to just come out without trying to hold them, and it's a pretty fast, neat procedure. So, Murli, do you think that there's anything different that you do? Because in the past there were a lot of different ways people are doing. Some used to go straight, some used to go biplanar, or some would retract conjunctiva, some not. So, do you have any fixed way of doing it? Or?
Yeah, I mean, two things I pay attention to. One is we need to displace the conj a little bit.
Okay.
And then you go obliquely initially and then turn it to aim at mid-vitreous cavity. I mean, that's what really gives you the healing nature of the track.
So pulling the conjunctiva has the big advantage that at the end of surgery you have a wound which is partially covered with a conjunctival port which is different than the scleral port.
Yes.
But because of that, do you sometimes find a problem if there is a wound leak at the end to find the right place to suture? Because sometimes you can't see it. You know, there is some fluid seeping out and it balloons up the conjunctiva. And at that time I feel that I wish I had made a straight entry just because I know exactly where it's coming out. So do you have any tips on that, or it's just that we do find it by giving some pressure or something and get along?
I mean, it's never been a problem to find it. You know, if it's ballooning, what I do is I'll just clamp the infusion and we need to open up the conj. And what I have learned and what we all have learned from MIVS is that you don't need, if you don't suture the conjunctiva with Vicryl, the eye heals very fast. So I make a flap in such a way that I don't need to suture that.
Right.
And then I am able to find the sclerotomy quite easily. I mean, that's usually you have to dissect the tenons a little bit.
Okay.
And you know, you just have to ask somebody to irrigate this area because you're not done cautery, so there'll be some bleeding.
Bleeds, yeah.
But you will find it. I mean, it's not a big problem. Okay. But only tip I would like to give is I make a flap in such a way, the conjunctival opening in such a way that I don't need to suture it.
Right.
And I avoid making the opening right where the sclerotomy is. I just make a few millimeters away from it, right, so that, you know, the suture also is nicely covered by your conj.
All right. So we go to the next step, which is a surgery for retinal detachment, for which you are doing a vitrectomy. So this would be a standard process. What you see, a core vitrectomy being done at the beginning. There's a superior hole here, which you see. There are a few other smaller holes in the inferior periphery also, but the main hole is superior with this horseshoe tear. So we go in close to that hole after doing the core vitrectomy, and now with these high-speed cutters, it's a bit easier to go and closer to these breaks and remove the vitreous as far as possible. And after that, once you have cleared everything, you would go for an air fluid exchange at some point once you know that the vitreous is free from that area. So here, because there was some vitreous still adherent, we've also done some staining with the triamcinolone to make sure that we have removed all the vitreous. Sometimes these cortical sheets still remain even though the main chunk of hyaloid has come off, and is more common usually in the myopic patients that are there. So once you've done that, now we know that it's totally mobile. I would do an air fluid exchange using the cutter itself. Because the ports now are so small that in the past we used to change to soft tip cannulas and do that at times. But now if the access to the retinectomy or the hole is easy, I just use the cutter to pretty much do that. So this is a standard procedure which I would use for treating a retinal detachment on an MIVS forum. So Shobhit, any?
Yeah, I differ a little bit in my approach. If it's a pseudophakic RD, first I see if there is a little bit of loose pars plana epithelium or some small choroidals, I prefer straight sclerotomies instead of biplanar sclerotomies, especially when using 25 gauge instrumentation. Otherwise, the biplanar is fine. Secondly, after doing a vitrectomy, when I'm doing a fluid air exchange, especially in a myopic eye, if I find my access to the primary brake is difficult, then instead of choosing use of perfluorocarbon liquid to drain from the peripheral brake, I prefer a 27 or even a 30 gauge small retinotomy in the upper nasal quadrant or wherever there is maximal fluid at the posterior pole and complete my procedure. That is one thing I find less traumatic. I find that the incidence of choroidal bleeds is less, and your chances of you're able to do a more atraumatic procedure.
So, Murli, would you also do something similar what he's saying, that would rather make a retinectomy, small planned retinectomy to drain rather than drain from any of these large pre-existing breaks? Would that be preferable to you, or you would only do a retinectomy if you feel the access to that break is a bit odd, awkward, or you're not able to reach there, or would you do a retinectomy?
My philosophy is to avoid making retinal breaks and use the pre-existing retinal breaks, and that would be my first effort. I would be very wary of creating another break in the retina. Two situations. One, if you have a very large posterior break, I feel it's a very good situation for fluid air exchange, and avoid PFCL. If you use PFCL in this situation, what happens is, as the PFCL seals the break, the fluid tends to collect anterior to the break and nowhere to go. And therefore I avoid PFCL in this situation, and I'd rather use fluid air exchange. If you have relieved all the membranes, fluid air exchange works very well.
I'm just showing you another situation where I've done a fluid air exchange, and as you can see, after air fluid exchange, this whole bulla comes up, and now the brake is lying here, which is free from fluid. The fluid has gone all posterior. Now in such a situation, it's difficult to drain from this brake. So here what I do is put in perfluorocarbon to push this fluid peripherally so that it connects with this brake, because many times you have this situation, you do an air fluid exchange and the fluid just collects posteriorly, it loses connection with your existing brake.
Yeah, this happens very often.
Yeah,
One trick I have is I use what's the extendable soft tip cannula.
Okay.
So with that, what I can do is I can go through a peripheral brake and extend the silicone tip to go to the pool of SRF in the posterior pole, and I find that this works extremely well to drain SRF through a peripheral brake when you're doing a fluid air exchange, and in my hands it has worked very well.
Okay. So
and avoided the use of PFCL again.
Actually, it depends on how much fluid you have in there. If you have a little bit of fluid, I'm quite happy to leave it.
Sure.
Rather than trying to put a soft tip cannula which will maybe rub against the RP and leave a linear track, or making another retinotomy which you don't want to do posteriorly. You want to make a retinotomy, make it peripherally, so you don't want to do that again. And then if you want to put PFCL, then you always think, there's a chance I might leave a bubble or something might go subretinal. So a little bit of SRF on the macula, in a macula of detachment, I just leave it alone.
Yeah, I agree with
90% attached, then leave it alone.
Suppose there is a significant fluid, then the other problem is that, see, you will end of the day go and laser that brake. Now you've lasered the brake thinking that this is the plane of the retina, but actually there's a lot of fluid in between, which once it irons out, will shift that plane which you've lasered.